My name is Dr. Daniel Quistorf. I'm a GP in Howick, doing natural medicine and general practice. We're streaming live on Facebook, which is why I got this thing in my hand. We got a good treat tonight. Martin Harris, longtime AIMA member, giving a talk. Is this your first talk?
No, I spoke probably 2 years ago.
2 years ago, yeah.
25, time for
Yeah. I remember when I was doing my neuroscience degree, we talked about dopamine, and they said the most addictive thing you can do to a rat is put an electrode in the reward circuit of the brain and make it push a lever, and we'll just keep pushing the lever until it dies. It's absolutely crazy. So dopamine's a powerful thing, and we don't really talk about it much in medicine. When we probably will learn all about it tonight. We'll have some questions at the end, and okay, we'll go for it. Thanks, Martin.
All right, good evening everybody. As Dan mentioned, my name is Martin Harris. I'm a pharmacist and a nutrition medicine practitioner. I've got a pharmacy out in West Auckland where I practice mainly from, and a clinic out there. So tonight we're going to talk about dopamine, and because I've had some real fun with dopamine this year with patients. It's actually been a bit of an education for myself as well about what we've achieved, and it's a little bit outside what I normally do, but it's been such fun I thought I'd share that with you tonight. But before we get into dopamine, I just thought I'd share a little bit about my story and what a nutrition medicine pharmacist is, because if you haven't heard of the term nutrition medicine pharmacist, it's because I've really just made it up. I got sick of explaining to people I'm a pharmacist, but then I also do blah, 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 blah. So I thought, let's just make it a nice small term. So like a lot of people, got into trying to find alternative ways of doing things after being a pharmacist for many years, faced with my own health crisis really. We got to this thing going through my family, ankylosing spondylitis, which is an arthritic condition affecting sacroiliac joints and spine and intervertebral discs and things. So in a severe form it can be pretty horrendous, and my father was always very disabled with this ankylosing spondylitis, and eventually it killed him. I think his death certificate said accident, but the accident was because he was so disabled that he had the fall. But my dad, when he was in his mid-20s, was 6'2", and by the time he got to his 70s, he was 5'2", so he'd shrunk a foot, because like all the bending over with the ankylosing spondylitis, and then the hips went, so he had, I think, 3 hip replacements that might have been each side, I'm not sure. He had a lot of hips done, and then because of the stooping and the bending at the hips, he had to bend his knees to see where he's going, because you can't move your neck when you've got ankylosing spondylitis. There's this little Z shape sort of wandering around. You should try driving with him. You get to an intersection and he can't move his head, so I don't know how he was seeing what's coming along, but somehow he managed to get eyes that kind of could peel around corners, I think. So yeah, it's a pretty horrible disease, and I didn't really want to go down that track, so I always tried to be healthy and fit. I used to be a marathon runner, and when I look back at the kind of training I was doing and the nutrition that I was getting at that time, it's a wonder I didn't kill myself. I mean, it was pretty awful. Back in those days I didn't know anything about nutrition, and all I knew was the public health guidelines, which was, if you cut the fat, then you'll live a long, healthy life, you won't get cholesterol, etc. So I used to survive on, white bread with jam on it for lunch. There's no fat in that, it's pretty mint. Chuck in an apple for when you're doing sort of 150 to 200k a week on your feet running, it's, the body's an amazing thing to cope with that. So, but despite, eating healthy, and doing a lot of exercise, I got diagnosed with ankylosing spondylitis in the late 1990s. And not wanting to go down the same track as my dad, and I knew about all the new flash drugs that were coming out, all the biologicals, etc. And I thought, well, I don't want to go on those. I'm not a very good pharmacist. I actually don't like a lot of the drugs that we dispense, because I'm just aware of all the side effects that they have, and if you need the medicines as a last resort, that's great, but if we can find something that we don't need them, then that's even better. So I went on the search for how I could turn off my arthritis, which is really what brought me to nutrition medicine. I went to a lecture by Professor Mel Sidney Smith, who is often considered the grandfather of nutrition medicine. I think he's retired now, retired about 5 years ago. He was based in Queensland in Australia. So I enrolled in his master's program in nutrition medicine, and then that's when I started to put in place the things that I was learning in my own health and the health of my family. And then I thought, this information is too good not to share, so I started a clinic within my pharmacy and started to treat people on a one-to-one basis in sort of in-depth consultations, rather than, you can imagine as a pharmacist, you're just sort of seeing people very quickly on the shop floor and you don't really get to discover a lot about them. So, long story short, I switched off my arthritis, and which is what my desired result was, but what I didn't expect to happen was I really switched on my radiant wellness. And at the time that I was really at my worst in terms of the arthritis, I used to get really sick, really tired in the afternoon. Like, I was in my 30s and I would I was working a corporate job and had this big glass office, and I'd have to have a sleep in the afternoon. Now, if you've got a glass-walled office, it's a bit embarrassing having a sleep in your office, so I used to have to go out, get in my car, drive around to a quiet street, have a snooze for about 40 minutes and go back to work. So I was really not well at all. But now, the young ones at work, we're standing up all day as a pharmacist, and I can outlast them really easily. So more energy, think clearer. I feel really well now compared to just struggling on before. And that's really what I wanted to share in my journey with bringing nutrition medicine through the pharmacy, is changing the way that pharmacists interact with people and what they can offer those people. The strategies that I used for getting well, yoga was a big one. I think that yoga was really instrumental in getting well, not only just for the physical movement and just probably calming down from an obsessive exerciser into just something that's a bit more chilled. But I ended up doing my yoga teacher training in 2016 and sort of diving deeper into the philosophy and the whole the effect that yoga can have on the mind, which is really powerful. Meditation, I think there's a lot of the answers are just in the silence, just being silent, and that sort of relates a bit to dopamine. We'll talk about how dopamine affects sleep, and it really is the fact that sort of quietening the mind. Diets is a really large part of that. As you can imagine, it's not hard to get better than jam sandwiches. So that's a huge part. Supplements obviously had an effect, and the exercise that I did. So in that time, I've only had one exacerbation. That was in 2017. I went to a conference in Fiji, and about half the delegates at this conference, there was about 500 of us, it was a big conference, about half of us got food poisoning. So we woke up on the Saturday morning and so many people were green, had been vomiting, diarrhea all night, and I hadn't been, but I woke up feeling like, oh, I'm so sore. And like, how many beers did I have last night? It's like, can't be that many. So tried to run it off, go for a run. I always just run when I'm not feeling that well. It's what I love. But it just got worse and worse. So after about 6 weeks of deciding to, get better and better at your diet, up your supplements, everything else going better, after 6 weeks, it got to a stage where I actually couldn't get out of bed. And so it's quite a severe exacerbation. Went to a rheumatologist who, you guys probably know Fraser Burling. He's kind of thinks a lot about nutrition, so he encouraged me to become vegetarian at that stage. So I think that helped as well. But I ended up, just so I could get out of bed, taking steroids and COX-2 inhibitors. And that's the good thing about drugs. When you're really deep in that hole, they help me to get out. That allowed me to go back to yoga, and that's when the improvement started to happen again. So pretty big exacerbation. Fraser told me it would take me a year to get well, if I got well at all. My CRP was in the high 30s. It should be less than 5. It's an inflammatory marker. But in 3 months' time, I was well again. So I think that's the background of nutrition medicine, just giving you a resilience. So despite the fact that the reactive arthritis floored me, it was a really quick recovery. 3 months seems a long time, not quick, but compared to what I was told, it was good. So this is me practicing what I preach. grounding on the beach, sunrise, negative ions off the water, time with the creatures of the world. That's Charlie, who's no longer with us, but yeah, one of my favourite photos. Right, so chronic disease. This is the bit where it's a little bit in what I'm going to talk about tonight isn't really consistent with what I believe and what I practice, because I think chronic disease is an imbalance between our genes and our lifestyle. And that certainly was the case for me. You know, my genes are really poor, and my lifestyle with the jam sandwiches and high stress with work wasn't really helping. So the magic bullets aren't really that common, but every now and again you do find some stuff that's pretty exciting, and that's what I've found with dopamine this year. You know, I don't really believe in just a magic bullet, but we've had some really sensational cases of people's dramatic improvement in health just with boosting their dopamine levels. So we'll go over that today. So, I mean, I've had some other cases, you know, some other nutrients often can create big changes. You know, I've had some patients over the years with, you know, lipoic acid and just complete resolution overnight of nerve pain, for example, and some of those things happen every now and again, but dopamine, it's been pretty consistent with the right people on it, have been getting pretty amazing results, which we'll go over. So the way I generally work with my pharmacy is that we talk to people about their diet. So we know that, you know, eating well has from a number of areas, number of angles is important. My definition of a low inflammatory diet and a healthy diet changes. It just keeps evolving over time. I went to a conference last year, and there's the, I can't remember the name of the lady's name, from the Genomic Kitchen. Everyone's come across her work? She does a lot of work on the blue zones where people live to be over 100 and what they're eating, and she's got a huge list of foods that interact in all the inflammatory pathways, up-regulating NRF2 and all those things. So some pretty amazing stuff coming out with diets. And the one thing I took out this year was radish leaves. Do you know how hard it is to buy radish leaves? They chop them off. Yeah. So I've started to grow my own radishes. Yeah, so basically starting at the top and working down, and if you, as you need, go down the step. If you need the drugs, you know, that's great, but let's try and work on all the stuff in between, so that all helps and makes it work better. So as part of that, we've got a nutrition medicine clinic in my pharmacy. I've currently got 2 practitioners who are naturopaths, herbalists, and Neuralink trained. I've got a clinical nutritionist who was supposed to be here, but I don't see her out there, and 1 health coach and nurse. But the main thing for me, really, that's working with patients who are quite sick, so there's a need for that, but just trying to incorporate it within the pharmacy. In a pharmacy setting, you see all these people coming in that they don't even know that their lifestyle is impacting on their health. They're sort of the great unwashed, and so if we can have some sort of impact on them to stop them getting as sick as the people that need to see us in the clinic, then we can have a really big impact on the health of patients. So that really is my calling, is to try and bring nutrition medicine down to a level that people can access through pharmacists that are interested in doing that at a point of care. And I have taught, I teach a nutrition medicine program to pharmacists, and I've taught over 100 pharmacists so far, and so that's kind of making the pool bigger and wider, which is quite nice. But we do try and do it just in the pharmacy, people off the street, which I think is a really good model. Like, pharmacists are really accessible. You know, there's no barrier to come in, really. If you walk in, you don't like them, you walk out again. You don't have to make an appointment. You don't have to go into a closed door. There's no cost to see a pharmacist. So it's sort of leveraging off those strengths and then adding on the nutrition medicine knowledge, lifestyle medicine knowledge. And so, yeah, huge untapped resource. But anyway, it's not about me and my pharmacy, but to just give you that background to put in perspective the dopamine information. So how did I discover dopamine? Well, the gentleman responsible was a patient of mine in the pharmacy, Paul, and I was giving out his medicines. Now, you think being a pharmacist, it's a pretty easy job, you know. The doctor tells you what to do. You just put pills in a bottle with a label on them and give them out, you know. Actually, it is pretty easy. But we have so many issues with the supply chain because Pharmac has preferred suppliers. We're at the end of the world, and we've always, you know, we ran out of paracetamol this year, you know. It's kind of like you try and explain to patients, no, you can't have paracetamol. It's like the pub with no beer. It's pretty tragic. So anyway, this particular case, Paul was taking melatonin, and of course we had no melatonin out throughout the country. Just another supply issue. So I got talking to him about what we could do to help him with his sleep, and then he started to mention to me that he had didn't have difficulty getting to sleep. He slept fine, but he was very active in his sleep. In fact, so active that he would thrash around, he would get up and walk, he would break things in the room, he would give his wife black eyes. It was like really severe, just thrashing around in his sleep. And this is why I like to talk to patients so you can get a bit more of a background. I said, I know what causes that. Thinking again, you know, the magic bullet. I've got a single thing that'll cure that. So I was trying to think, was it magnesium? Was it iron? Was it the B vitamins? I know, it was dopamine. Because dopamine has been shown to paralyze the voluntary muscles while you're sleeping. So you can be doing your cartwheels through the daisy field in your sleep, but you're not actually doing it in real life. You're actually, your muscles are paralyzed. So that sort of made me think about the dopamine and how it can be useful in clinical practice. So yeah, that's how I discovered dopamine. When I say I discovered dopamine, I actually didn't discover dopamine, but how I discovered how dopamine can be helpful in my practice. So when I started to do a bit more research into dopamine, there's some pretty good evidence about its role in mood, motivation, memory, movement, and sleep. So you can imagine if you get all those things right, you're in a good mood, you're really motivated, your memory's good, you're getting good sleep, you know, you're going to be a pretty useful sort of member of society rather than if you are poor on all of those things. So let's talk about all those one at a time. So dopamine and mood. As a pharmacist, when we think about mood, you think about serotonin. It's kind of what we're trained in. You know, it's serotonin, the happy hormone. All the antidepressants pretty much work on serotonin. Some of them also work on noradrenaline, but there's none that specifically target dopamine, which is really interesting because we know that anhedonia, complete loss of pleasure in a severe form, is a dopamine deficiency state. So I don't know why we haven't sort of put the things together and thought about antidepressants that target dopamine. There are some that indirectly do through the back door, but none of them target it directly. So we know that dopamine's pretty integral to mood. And the other thing about all the drugs that target serotonin is that they only are really effective in about a third of patients. A third of patients do pretty well on them. A third of patients do, it's better, but it's not great. And a third just don't do well at all. The issue around serotonin also is that the selective serotonin reuptake inhibitors, the SSRIs, will increase serotonin levels straight away. And then by about 4 weeks, the levels are back to baseline again. The therapeutic effect happens in about 4 to 6 weeks, so they don't actually match anyway. So it's still, I guess, there's a few theories on how the SSRIs work, and it may be through brain-derived neurotrophic factor and a few other things that they're looking at. Whereas my experience with dopamine is that we're getting some results pretty quickly, and I'll explain those cases a bit later, which is nice. So with mood as well, stress tolerance and anxiety has been associated with dopamine and mood, and that's related, I guess, to the activation of the amygdala, which is the centre that is for fear and threat. And it's really interesting, you know, I talk about the causes of ill health versus dislocation. The monoamine hypothesis was developed back in 1959. There's a doctor, can't remember who it was, that discovered that all his patients that had tuberculosis that were getting treated with this drug, iproniazid, were abnormally happy. Like, why are these people so happy? You know, they shouldn't be this happy, especially if you've got TB, you know. So that's when they started to look at what that was doing. It was having an effect on serotonin, and so the monoamine hypothesis started back then. And then in 1968, someone else came up with the stress hypothesis, looking at all the glucocorticoids and the effects that has on a number of other areas in the brain. But as luck would have it, the medicine went down the monoamine theory rather than the stress theory, but I think that's starting to reverse now as we're looking at oxidative stress and inflammation and those things for brain health. But having said that, we're still going to talk about a neurotransmitter, a monoamine, today because it's fun. One other thing that's subject to a lot of research at the moment that shows there probably is a big association between dopamine and mental health is this reward deficiency syndrome. And that's associated with addiction, aggression, and eating disorders. In fact, they're saying that, you know, for example, 70% of alcoholics have got it's kind of like a genetic polymorphism, not quite in the dopamine, which means their dopamine D2 receptors are down-regulated, so they actually don't get enough response from dopamine like they otherwise would have. And so that means that with dopamine, that's when you get your pleasure and your reward from. And so if you're not getting your reward from your normal levels of dopamine, you look for something else to stimulate those pleasures. So that's when people look to addictions, whether it's drugs or alcohol, food, sex, gambling, all those disorders. There's quite a high prevalence of these people with this dopamine reward deficiency syndrome in that group. In fact, there's actually a journal dedicated to it. I'm not sure exactly how prestigious that journal is. I think not very. So there's the expression of the dopamine D2 receptor. Yeah, and it actually affects 30% of the US population, which doesn't mean to say that 30% of the US population are all drug, sex, alcohol addicts, but it just means that those people are perhaps not getting quite as much pleasure from their daily activities as they otherwise would have. So it's a spectrum. And obviously there's other causes of those addictions as well, not just the reward deficiency syndrome, but it certainly seems to be a reasonable factor in there. Dopamine and motivation. So that's kind of your desire to get up and do things in the morning. And we know that a few things that link these together. Dopamine actually increase in times of stress, which commentators say is to allow people the ability to get up and act. So, you know, get up and look for a new job if you're stressed out at your job, or go for a walk if you're annoyed with the people you're around, and all those sort of things. So it's just a way to motivate us to get up and going. An interesting study I found that looked at go-getters versus slackers. I don't know how they recruited people for this study, so could all the go-getters go over that side of the room and all the slackers go on that side? I'm going to measure your dopamine levels. But it did find that the go-getters, the motivated people, had higher levels of dopamine than the slackers. I don't know how they tested that to make sure people were being honest. Low libido is associated with low dopamine as well. I'm not quite sure how this comes under motivation, but I guess someone with high libido is highly motivated, I guess. Yeah, not sure. Yeah. So mental exhaustion, I guess if you're mentally exhausted, you're not too motivated. So that's also associated with dopamine deficiency, and particularly the inattentive form of ADHD associated with low dopamine. And a lot of these people are actually end up abusing substances as well, just to get some of that pleasure, and there's quite a strong link there. So a link between dopamine and motivation as well. Dopamine and movement. We know that people with low dopamine levels move slower, have poorer reflexes. You can imagine poor Eeyore there. He's obviously very dopamine depleted because he's always depressed and moves so slowly. Eeyore. Certainly in Parkinson's disease, you know, all the movements and things that are a problem, but restless legs and tremors have also been shown to be linked to dopamine. It's the sleep part. So we know that if you've got low dopamine, you'll have daytime sleepiness. And in fact, at extreme levels, narcolepsy, then that'll be treated with dopamine-based stimulants. So it does seem to have a role in sleep. It was thought originally that it didn't have a role in sleep because dopamine levels are higher in daytime because it is motivating and activating. And the nighttime levels didn't seem to vary too much. It's just the total levels seemed to be low. But when they did more in-depth studies, they found that Dopamine levels actually spike during REM sleep, the rapid eye movement sleep, which is your dreaming sleep, which makes sense because if you're doing your cartwheels through the daisy field, that's when you want your dopamine to be higher to stop you from actually doing your cartwheels. And so the studies are showing that there is a link there. The other links with sleep, people with low dopamine often dream in black and white. They often don't remember their dreams. Their dreams are often more severe. This is with the upregulation of the amygdala, the fear center. So they're unpleasant. When they do remember them, they're nightmares, and sometimes they're in black and white as well. So, makes sense then that we'd want to boost dopamine levels, I guess. So ways that we can do that, we can supplement with the precursors, which we'll go over soon, and all the enzyme cofactors, the pathway that makes dopamine. Mental activity is helpful for boosting dopamine levels. Exercise, visualization and anticipation of pleasure. I looked at a study on a mouse model where they're looking at normally dopamine levels rise after the firing of a neuron after an activity has been done. So that's when doing your exercise and some mental activity happens. But this particular model looked at, the increase in dopamine was actually before the mouse was stimulated. So there seems to be some sort of ability with visualization to. And we just need to think happy thoughts, regularly throughout the day, and that can help boost our dopamine levels. A sense of achievement can also help to increase dopamine levels. So setting small incremental goals, you can achieve them much easier. Rest, sleep, reduce stress, less inflammation in the body. Microbiome health, well, that kind of fixes everything, doesn't it? Fixing your microbiome, so that stands to reason. But definitely the good bacteria are producing neurotransmitters in the gut, so that has a direct impact. So what is the pathway for making dopamine? Well, we start with an amino acid phenylalanine, which gets hydroxylated with this phenylalanine hydroxylase enzyme to tyrosine, and the cofactors are oxygen and tetrahydrobiopterin. Tyrosine then gets hydroxylated to L-Dopa, and again tetrahydrobiopterin, oxygen and iron as cofactors. Then it's decarboxylated to dopamine, and that requires vitamin B6. And then there's a dopamine beta hydroxylase enzyme requiring oxygen and vitamin C for noradrenaline or norepinephrine, and then SAMe methylating reaction going down to epinephrine or adrenaline. So you can see there's lots of places you can intervene in that pathway to help boost dopamine levels, and we'll go over some of those. Dopamine, you saw on the previous slide, it goes on to noradrenaline and epinephrine, but it depends on where it is in the brain and the body as to whether it does that or whether it goes down other pathways. But there are enzymes that break it down to inactive metabolites, so it doesn't always have to go to noradrenaline and adrenaline, and that's the COMT enzyme, the monoamine oxidase enzyme, and the aldehyde dehydrogenase enzymes. I'll just break it down to inactive metabolites. So that's where some of the medicines actually, like the monoamine oxidase inhibitors, meclobamide's really the only one that we use now, can actually boost dopamine. It's the only drug really that gives dopamine a boost that we use for depression. But dopamine can also be oxidized and create some damage, and that's one of the proposed theories around Parkinson's disease, where dopamine levels drop dramatically is the production of these free radicals and quinones out of dopamine that actually poison the cells and create a lot of damage. So if we're going to look at boosting dopamine, then tyrosine would seem like a good option. It's a reasonably easily got economical amino acid. Studies that have looked at it have used reasonable doses, 3,000 milligrams or 3 grams in the morning. There's actually a small French study, and they studied, it wasn't that large, but all the patients that were in the study had documented depression and documented dopamine deficiency, and the results were just phenomenal. All those patients got really well, really, really quickly, when we'd proven that they had a dopamine deficiency to start with. So, tyrosine going through that pathway to dopamine. It does require mental activity and stimulation. It's a bit like, your erectile dysfunction drugs. They kind of need stimulation to work. They just don't work on their own. Tyrosine is best if taken without a lot of other protein. These large neutral amino acids compete for absorption, so taking your tyrosine with your steak and eggs is probably not going to be as good as taking it with a small amount of carbohydrate and maybe a little bit of orange juice or something. That actually enhances the absorption a little bit better. And of course, there's all those cofactors in the pathway, so if you're deficient in a number of those, then that's going to be a bit of an issue. And while vitamin C is important for that, I mentioned the decarboxylation of dopamine to norepinephrine. Vitamin C actually blocks the dopamine receptors, so vitamin C's a bit of a playing both ways. Safety of tyrosine. Toxicity can occur in doses over 2,000 milligrams per day, and that's the list there: constipation, agitation, blistering on toes and fingers, growth suppression. In pregnancy and lactation, just like any nutrient you look up on a decent database, it'll say insufficient evidence. So frustrating, let's just get a whole group of pregnant ladies and do tests on them just so we can know. Maybe not. Is that recorded? Sorry. But I did see one study where they looked at a single dose of tyrosine, and the rise of tyrosine levels in breast milk was actually similar to those that are found in infant formulas anyway. But, first do no harm. We know that tyrosine can increase blood pressure in hypertensive patients. It tends to normalise blood pressure, really, but in hypertensive patients it tends to go up a little bit more. And I think that's related to the fact that tyrosine can be converted to tyramine instead of dopamine, and that can cause like a hypertensive crisis in patients. I mean, that's why in the old days with those monoamine oxidase inhibitors, I mentioned meclobamide's a reversible inhibitor of type A, but the old ones were very non-specific. So people that were on those medicines and ate cheese, which contained tyramine, would have these major hypertensive crises. And that's kind of the reaction that happens sometimes in these people if the doses get up high. The conversion of tyrosine to tyramine, it's confusingly similar names, is more likely when you've got low stomach acid. So again, getting the patient well with their digestion and everything is really, really important. What else did I want to say about that? No, that'll do. Just that I did see one study that said in rats, when they looked at the conversion of tyrosine to tyramine, it seemed to get quite significant at doses as high as 1.5 grams per kilogram. So if you think of an average 70 kilo person, that's about 100 grams of tyrosine. So it's a pretty high dose. We wouldn't see that in practice. Well, I hope we wouldn't see that in practice. Sometimes because tyrosine is your motivation, you get up and go activating, people don't sleep at night, so you can balance it with a little bit of tryptophan, 500 milligrams at night, and I know a lot of practitioners do that. 3,000 milligrams of tyrosine in the morning, 500 milligrams of tryptophan at night, and you balance that. Bearing in mind that tryptophan goes on to serotonin down that pathway, so if anyone's on an SSRI or any of the other serotonin drugs, you need to be cautious there. And of course, that schizophrenia is really a dopamine excess thing, and it's treated with dopamine antagonists. So anyone that's predisposed to schizophrenia, you probably want to go pretty cautiously with trying to boost dopamine. My bread and butter, drug interactions, that's what they pay me for. So obviously, if you're putting tyrosine in there and it's boosting dopamine levels, and you've got a drug in there that stops the breakdown of your neurotransmitters, then that's not a good thing, so you need to avoid it. You'll get an excess. An interesting finding is, an interesting thought I had, levothyroxine. So the thyroid hormone that is prescribed in general practice is tyrosine with 4 iodine molecules attached around it. So actually one of my patients that did really well also had low thyroid. So I'm kind of thinking, was it so much the dopamine that was boosted, or was it the thyroid that was boosted? So I don't think that's not a showstopper. It's just of interest. It may actually be beneficial. And most people on levothyroxine are having their levels measured anyway. Levodopa, used for Parkinson's disease, which is really low dopamine. There is some evidence that they compete for absorption, so you can space them apart. There is some studies that are looking at using tyrosine early on for patients with Parkinson's disease and leaving levodopa for later, because levodopa does work well, but then it wears off. So if you can save it for later, that may be a good thing. So yeah, you could probably use levodopa and tyrosine together, but just not at the same time of the day. And we know that one of the showstoppers with levodopa is orthostatic hypertension, which tyrosine may be of benefit with as well. Some studies there. Obviously adrenal tumours and some other tumours, you want to avoid tyrosine use as well. Other dopamine boosters, this is probably what a lot of people here are familiar with. Saffron has a direct impact on dopamine levels in the brain. It's also antioxidant and anti-inflammatory for mental health. Theanine inhibits COMT, which if you remember a few slides back is one of the enzymes that can break down dopamine to its inactive metabolites. So inhibiting COMT is a good thing. So therefore it ends up with higher dopamine levels. Rhodiola is not that specific on dopamine, but it can help, acting a bit like a male inhibitor. It just kind of generally, everything sort of gets a bit boosted with rhodiola, which obviously you can't use with serotonin agents for risk of serotonin syndrome. SAMI may increase dopamine production. Obviously some of the drugs, methylphenidate or Ritalin for ADHD and dexamphetamine. And of course making sure they're replete of all the enzyme cofactors would be a good strategy as well. Right, so how has that worked in practice? So I mentioned Paul at the beginning, the guy that started me down this track of looking a bit deeper into dopamine. So his sleep disruption was severe. I gave him tyrosine 3,000 milligrams a day, and he persevered for 8 weeks without much change in his sleep, which kind of disappointed me a lot because I thought I had the magic bullet. You know, it's like, I've discovered the cure for this guy, and he didn't get better. Like, not great. So I'm still working with him, and we're looking at maybe some of the cofactors and other things to look at that. But he's had really no response at all. After that, when I was doing my research on its activity and mood and motivation and everything else, and I decided I'm going to try this on a number of other patients in my pharmacy, I developed a questionnaire, which I didn't do with Paul. And this has got, you're welcome to have a copy of this, I printed out 40 or so. It's got 15 questions on it, and basically based on your answer to those questions, it'll tell you whether you're unlikely or likely to have a dopamine deficiency. So Val did my questionnaire, and she decided that tyrosine would be her cure. So in my pharmacy, I'm a little bit, I'm a bit of a cowboy when it comes to doses. I like to give people therapeutic doses. I don't want to muck around. A naturopath I work with has, one of her sisters died of a drug overdose about 30 years ago, and she's really conservative, so I'm always pushing doses, and she's always putting the brakes on, which is why some of these dosages are a lot less than what I would recommend, but that's because Robin's gone in there and gone, let's just put the brakes on. It's a nice balance, myself and Robin, but anyway. So on 2,000 milligrams a day, Val rang me up and said, that tyrosine is a marvellous thing. I had no energy, I was tired and depressed, even on my medicines. Now I'm doing spring cleaning and have lots more energy. I'm feeling a lot more positive. After 1 week. It's kind of like, whoa, that's interesting. Yeah. So Val's on about 14 different medicines. She's got a lot of gut disruption, a lot of pain, a lot of asthma, quite a lot going on there anyway. So it's interesting that it's kind of a bit of a magic bullet for Val. And then we had Karen, who I first got involved with in 2015. She came home from her summer holiday, came to see me, says, Martin, I couldn't carry on with my holiday, I'm feeling really bad, depressed. I think she was anxious as well, I can't quite remember now if there's anxiety in there. So I started her on SAMI thinking this is my magic bullet back then, everyone does well on SAMI, it'll work really quickly, she'll love me. And then she came in the week later with a prescription for sertraline, and I'm offended. My SAMI didn't work? She goes, no. Okay. What made me feel better is the sertraline didn't work either. So then she got put on citalopram and had a bit of an effect, and then for the last 4 years, we've just been prescribing her, citalopram. We've been prescribing her citalopram, or we've been dispensing citalopram and doxepin that the GP's prescribed. And I assume she was doing okay on those. I sort of didn't really have much of to do with her on a direct basis other than dispensing her medicines. But then she discovered our dopamine questionnaire and decided she scored quite highly on that questionnaire as well. So she, again, got poached by Robin and the dose taken down to 2,000 milligrams a day. And she said after 1 week, she was back to her old self. And this is some of the things she said. She's able to work full days. Before that, on the citalopram and the doxepin, she was only able to do every second day. She was washed out after 1 day. In fact, she often do half days. She was waking up feeling invigorated. She had a desire to start the day. This is all the motivation stuff. High levels of energy. She said she was still aware of her stress. It hadn't gone, but it didn't bother her anymore, which is really nice. She came back a few months later and asked how she's getting on, and she said, the effects worn off. And so I looked up, she hadn't bought any more from me, and so I encouraged her to buy. I asked what she'd buying. She'd bought it from, can't remember where, but it was, I guess, an inferior product, because when she went back on my one, the effects came back up again. So now probably about 6 months later, she just is obviously committed to my brand of tyrosine because it works really, really well for her. So another kind of magic bullet moment, and such a huge impact on someone's life for one little thing. And I guess the whole thing about the magic bullets, it's like when I was sick and needing the steroids and the COX-2 inhibitors and things just to get going, they're just about putting people on a level playing field so they can then do all the other good things in life that they need to do. I've got a patient with depression at the moment, actually, that I'm really struggling. He just won't take anything. He believes he's got to work through it just with the way he thinks about the world and going for walks and things. But I'm saying, let's at least do some tests to check the basics. Are you actually on have you got both your shoelaces tied together and you're wondering why you don't keep up with everyone else on the run? Right, Christine. So by this stage, we're all getting really excited about dopamine. So everyone's doing the questionnaire. And so Christine turns up and she does it. And she doesn't score that highly. She's only kind of middle of the scale. She goes, should I do it? And I'm thinking, wow, it's working for everyone else. Why not? So she had a history of gut issues, hormone issues, migraines, a lot of stress in her life. She's the only caregiver for a disabled child who's actually an adult now. So, 30 years of looking after a disabled kid. So always struggling with the health. Again, Robin intervened, thank goodness, because she got heart palpitations even on a lower dose. And I just wondered whether, with all her issues going on there, whether she'd been converting stuff to tyramine rather than going through to dopamine. But again, she didn't come up very highly on the questionnaire. So I guess, if I was being more rational in my thinking, I probably would have said, yeah, not for you. Let's work on some of the other issues. I think where I practice in Massey, it's a pretty low socioeconomic area as well, so getting people to do expensive testing and major changes to their diet and more expensive foods and lots of different supplements is always hard work. So getting tyrosine's cheap, so a cheap, quick fix is actually attractive for many patients just on an economic level. So that's my questionnaire. How that's out good. It's pretty simple. For each question, you just mark never, mild, occasionally, moderate or severe, and you get points for each one, add up the totals, and if your totals are reasonably high, then we think you've got a high likelihood. If they're low, then you've got a low likelihood. That's actually the questions in a state that you can actually read them in. So being dizzy or lightheaded on standing up, sunburning easily, tendency to be moody or depressed, feeling tired or exhausted excessively, fluctuating feelings, crying a lot, sleepy during the day, stomach cramps, bad dreams, nightmares, restlessness, sleeping, lightheaded after missing meals, reduced sex drive, excessive sweating, maintaining an ideal weight difficulty, and excessive thirst or urination. So they're all pretty non-specific symptoms, but when you put them all together, it's all painting a picture that this person may have issues with dopamine. And that's certainly what I've found with patients that score highly on the test. We've had these miraculous results. We had another lady, Angela, and she came in, and her 15-year-old daughter and her both did the test, and they both came up really, really high. And this lady's had a lot of tragedy in her life, lost a child and other things. And again, like days later, it was actually 2 days later, she came in going, wow, this is an amazing effect. So the first couple of patients, it was kind of like quite confronting. It's kind of like, well, anything works this quickly. But there have been some really good results. So, take-home messages, like I don't believe in magic, but we have had some really good results. And so I think anyone that's living with low dopamine levels, it's like their shoelaces are tied together or they've got their handbrake on. It's really, really impairing them. We still need to address all the underlying factors as well to health and lifestyle. One paper I read, and I'm not quite sure I agree with them, but the microbiome contributing 50% of dopamine. I think most of it's in the neurons, but anyway. So just being aware of those clinical signs and symptoms in practice may help you to get a good win on the board for a patient, get their trust, and then you can work on those other factors for them as well and get them to radiant wellness. So, can't have a presentation without a cute pussycat in there. Any questions?
If you're starting people on these drugs, how long do you keep them on it for? Is this something that they're going to take you back the rest of their life, or then do you try and wean, wean it once you've got the desired effect?
I'll repeat the question because people are listening online. So the question was, when people are on these drugs, how long do you have to keep them on? Is it a forever thing or just for a short period of time? Right? And by drugs you meant the things like the tyrosine, the supplements, the nutrients, yeah. I guess it depends a little bit on what's going on with the patient, and I don't know with all these patients without doing a lot of in-depth testing what might be going on with them. Taking things like tyrosine, magnesium, B vitamins, zinc, iron, all those things to replenish is safe in the long term, so there's no harm to it. If there's something like a dopamine receptor downregulation, and that's a genetic thing, then they may have to do it for a long period of time. If it's because their body's out of balance and their microbiome's creating stress and inflammation in the body, which is depleting all their dopamine, then once you fix that, you won't need to keep them on. So I think it depends on the individual.
I've seen a couple of papers suggesting that men have high levels of COMT as women use it up for estrogen, and that reduces men's basal level of dopamine. Do you think that might be the case? And do you think that's a problem?
So the question was, do men have higher levels of COMT, which is reducing dopamine levels? Yeah. I've not seen any information on that. Sorry, I can't comment. I know there's a lot of genetic mutations, SNPs and things that affect the COMT enzyme. The whole genetic thing it's interesting because there's 23,000 genes that we've got, plus millions of genes that our bacteria are providing to us, and so if one's going one way and another's going another way, where do we end up? So, but I'm not aware of a gender difference there. There's a question here.
Easier question. Any drug interactions with tyrosine and tegretol?
Tyrosine and tegretol drug interactions. I didn't find any, but I wasn't specifically looking. I've got a drug nutrient database we can look up afterwards if you like. Have a look.
So, thanks. But one of the things that I see a lot clinically is the flip side of what you've been talking about tonight, where people do have polymorphisms on their COMT enzyme, and there are two major ones that contribute to diminished degradation of the catecholamines. So they build up and they create the superhedonia, the really high sex drive, the can't sleep because they're wired, they're crazy, and I mean, I could probably put together one like this. So I'm just a bit curious about where that the anxiety sits in here, because the anxiety also is a symptom of elevated adrenaline, which of course is part of the dopamine metabolism pathway. And I see that hugely in those sort of type A people who they can't switch off, they just can't. So I'm just sort of curious, I mean, yes, the low dopamine is really important because that is involved in your reward, be in life type thing, but then there's this flip side of it, which may feed into what sort of the question that came from back here.
Yeah. So the comment was probably more a comment than a question about the fact that there's a whole lot of people that have got polymorphisms with their COMT enzyme and their genes for the enzyme, and therefore they end up at the high end with a lot of anxiety and you know, everything over the top, which obviously you'd have to be very careful about giving tyrosine to someone like that. It's very activating. But I think, you know, that's, yeah, those sort of people would be quite obvious to separate out, I would think, if you got that sort of person versus or the donkey that comes in, you know. Someone over here had a question.
I've got a couple of questions now to follow on from that. Often we see people with combined depression and anxiety. So you must see those patients too, and would you treat them with tyrosine, or does it make their anxiety worse? That's one question, but I have my own. Surely.
Yeah, so I guess you'd always have to have that in the... So the question was combined depression and anxiety, and whether you'd therefore try and boost dopamine in those patients because the risk of causing extra anxiety and getting people moving along. Yeah, I think you've got to have a little bit of, I guess, caution if you're using someone that's more on the anxious scale. I think there's a lot of... Yeah, and there's a lot of other nutrients that you'd probably want to try first as well, you know, and you know, again, talking about magic bullets, you know, I had a lady come to see me and her neurologist prescribed her N-acetylcysteine, and so she, fascinating, eh? So she came in to get it from the pharmacy, and we put her on theanine as well. This woman, she could barely talk when she came in. She was so anxious and so over the top, and barely able to communicate. And you know, 2 weeks later, on N-acetylcysteine and theanine, she came in quite lucid and calm, and that was quite a major improvement for her. I don't know what else the neurologist was doing with her, I don't think I'd go there in that sort of patient. It's a bit like, you know, you've got a bipolar patient and, you know, using SAMI, which can put people, again, more into the manic phase rather than keeping them steady in the middle. Although I do know a number of GPs around the place that have been prescribing SAMI for people with bipolar. So I guess it depends on the individual and how risk averse you are.
About the SAMI, your presentation, I think it was Karen, you said that you tried her on SAMI and then tried some other prescription medications as well. Do you remember at all what the dose of the SAMI was that you used?
So question around the dose of SAMI I used for the Karen patient I talked about earlier. I'm pretty sure it was 400 milligrams a day. So again, that could be too low. Yeah. But there's a cost factor as well. So if I started to tell her to go up to 3-4 a day, she'd probably not like me too much from a financial perspective.
I might just add a few things. Who's heard of the Shikimati pathway, right? That's the pathway our microbiome uses to make tyrosine, which turns into dopamine, or make the tryptophan that turns to serotonin. That's inhibited by glyphosate or Roundup, right? So all the food pesticides stops our gut from making this stuff. So that's a really important thing to know. We're probably all deficient in some way. The second thing is you can test, and we have a great functional tester here, Adri, and she's with NutriSearch, and you can test your levels of these things with the organic acid test.
Yep.
Cool. So that's the two stuff I wanted to add about the talk. Are there any other final questions about this? Okay, great. Well, let's give them a round of applause.
Thank you. Thank you. Yep, thank you. Got that?
So I'll just have a quick announcement. So we've set the date for our AIMA conference this year. Well, I guess it's next year now. March 7th and 8th. Save the date. We're also going to have I think a Friday retreat before then, if you want to attend. So we'll send out newsletters about that. Next month's talk was supposed to be about the latest and greatest with prostate treatments and testing and all that by John Appleton. And then he ended up getting surgery in Germany on his back, and now he wants to talk about that. But we're not sure if he's going to be fit enough to talk about it. So watch this space for next month's talk. If we don't get him, we'll either get Vanessa doing anti-aging and telomere testing and all of that, or I might just give a talk about fasting or something. Okay, thank you. Oh.
If you've got your email on list, which you will have if you've got a ticket, is I will email you the links for the presentation and the checklist. Thanks to Martin for sharing it with us. So you'll have those tomorrow morning.
Yeah, great. Thank you, guys.